What is the hantavirus? Hantaviruses constitute a globally distributed family of viruses that can cause severe, often fatal illnesses in humans. These pathogens are classified as zoonotic, meaning they naturally reside in animal hosts, specifically certain species of rodents, and can only cause disease when transmitted to people. Clinically, hantaviruses are responsible for two major syndromes, distinguished by their geographic origin and the organ system they primarily affect. In the Western Hemisphere, the Americas, hantaviruses cause hantavirus pulmonary syndrome, HPS, also referred to as hantavirus cardiopulmonary syndrome, HCPS. This is a severe respiratory illness in which the virus attacks the lungs, leading to fluid accumulation and respiratory failure. The most common carrier of HPS in North America is the deer mouse, and the Synnombre virus, SNV, is the prototypical strain linked to the disease. In the Eastern Hemisphere, Europe and Asia, hantaviruses cause hemorrhagic fever with renal syndrome, HFRS. This syndrome primarily damages the kidneys and vascular system, leading to internal bleeding, shock, and acute kidney failure. Key strains include the Hanton, Dubrava, Pumala, and Sol viruses. Notably, the Sol virus is the only hantavirus found worldwide, including in the United States. A note on distinction. Both HPS and HFRS are caused by distinct hantavirus strains and affect different organ systems, lungs versus kidneys, but they share a common theme: a dramatic, life-threatening systemic inflammatory response following infection. How is the hantavirus spread? Hantavirus is almost exclusively spread through contact with infected rodents, primarily their urine, droppings, and saliva. The primary route of human infection is inhalation. When dried, contaminated materials from rodent nests or waste are disturbed. The virus becomes aerosolized in tiny dust particles. Breathing in this contaminated air is the most common way people become infected. Other, less common routes of transmission include direct contact, touching surfaces or objects contaminated with the virus, and then touching the nose, mouth, or eyes. Ingestion, eating food contaminated with rodent saliva, urine, or droppings. Bites or scratches, being bitten or scratched by an infected rodent, rare. Human-to-human transmission. The exception, it is critical to understand that for the vast majority of hantaviruses, the virus is not transmitted from person to person. Casual social contact does not pose a risk. The single, notable exception to this rule is the Andes virus. This unique characteristic sets it apart in the hantavirus family. The hantavirus family is diverse, with specific strains being endemic to particular rodent species and geographical regions. Major variants can be broadly categorized: Old World hantaviruses, causing HFRS Hanton and Dubrava viruses, found in Asia and the Balkans, respectively. These are associated with a severe form of HFRS, carrying a fatality rate of 5 to 15%. Pumala virus, the most common hantavirus in Europe, particularly in Scandinavia. It generally causes a milder form of HFRS, with a fatality rate of less than 1%. Sol virus, a globally distributed virus, including in the Americas. It typically causes a moderate form of HFRS, with a similarly lower fatality rate. New World hantaviruses, causing HPS-HCPS, Synnombre virus. SNV, the primary cause of HPS in North America, transmitted by the deer mouse. Andes virus, ANDV, the primary cause of HPS in South America, notably in Argentina and Chile. This virus belongs to a broader phylogenetic clade of Andes-related viruses, which includes other pathogenic strains in the region. Crucially, the Andes strain is the only hantavirus in the world for which human-to-human transmission has been conclusively documented. This transmission requires close, prolonged contact with a symptomatic individual and is not known to occur through casual interactions, such as shaking hands or briefly sharing a room. The Andes virus is associated with a particularly high mortality rate, estimated at approximately 35 to 50%. This unique combination of inter-person transmissibility and high lethality makes the Andes strain a distinct public health concern. Symptoms and mortality rate. HPS-HCPS progression. The illness typically develops 1 to 8 weeks after exposure to the virus. It progresses through two distinct clinical phases: Phase 1. The prodromal stage. The initial symptoms often mimic those of influenza, making early diagnosis challenging. Symptoms include fatigue, fever and chills, headaches, muscle aches, especially in the large muscle groups, thighs, hips, back, shoulders. About half of patients also experience gastrointestinal symptoms such as nausea, vomiting, diarrhea, and abdominal pain. Phase 2. The cardiopulmonary stage. This phase begins 4 to 10 days after the initial symptoms and marks a severe, rapid decline. As the virus attacks the lungs' capillaries, fluid leaks into the air sacs, causing pulmonary edema. Signs include coughing and severe shortness of breath, chest tightness, low blood pressure, and irregular heartbeat. Once respiratory failure sets in, a patient can decompensate within 24 to 48 hours. HFRS progression. Symptoms also have an abrupt onset 1 to 2 weeks post-exposure and include intense headaches, back pain, fever, blurred vision, and facial flushing. The disease can escalate to dangerously low blood pressure, acute shock, internal bleeding, and severe kidney failure. The mortality rate of hantavirus infection depends entirely on the virus strain and associated syndrome. Fatality rates. HBs/HCPS, New World viruses, 38% overall. This ranges from 20 to 40% broadly, but specific strains like the Andes virus are estimated at 35 to 50%. HFRS, Old World viruses, varies significantly by specific virus strain. Severe, Hanton, Dubrava, 5 to 15%. Moderate, Sol, Pumala, less than 1%. Treatment and cure. There is currently no specific antiviral cure, nor an approved vaccine, for any type of hantavirus infection. The cornerstone of medical management is supportive care, provided in an intensive care unit. Early recognition and immediate hospitalization are the most critical factors in improving a patient's chance of survival. The primary goals of this care are to sustain organ function and manage catastrophic complications. Respiratory support. This is the most vital intervention for HBs/HCPS. Due to severe pulmonary edema and acute respiratory distress syndrome, patients require supplemental oxygen and, in severe cases, intubation and mechanical ventilation to breathe for them. Circulatory support. Medications, known as vasopressors, are used to combat dangerously low blood pressure, a common and life-threatening complication. Fluid management and organ support. Intravenous fluids must be carefully managed to avoid worsening fluid buildup in the lungs. In the case of HFRS, if kidney failure develops, dialysis may be required to filter waste products from the blood. Investigational therapies. The broad-spectrum antiviral ribavirin has been shown to be potentially effective for treating HFRS if administered intravenously and early in the illness, though its efficacy for HBS is not established. No specific immunotherapeutic agents are available, and treatment remains firmly grounded in aggressive supportive care. With optimal ICU-level supportive care, the survival rate for HPS can reach 60%, but the disease progresses with stunning speed, making early diagnosis and intervention paramount.